excited to have our own Sarah Sydlowski as well as guest speakers, Dr. Ardeshir Hashmi and Dr. David Brill. So just brief introduction. So everybody knows Sarah Sydlowski. She's an audiology director of hearing implant program, director of audiology innovation and strategic partners, and associate chief improvement officer at Cleveland Clinic. So she is currently an associate chief improvement officer, and she's really working to develop the culture of improvement in our enterprise. And she's also a co-chair of the Hearing Health Collaborative, which is a national group of physicians, audiologists, and professional associations and public health experts who are all just trying to improve healthcare in the U.S. And I think the hope of this grand rounds will hopefully inspire you to help us identify and improve the lives of millions of Americans who could be hearing better. And just to briefly introduce our other speakers, so Dr. Hashmi is the Enterprise Director for Center for Geriatric Medicine and the now Chair for Geriatric Innovation at Cleveland Clinic. And his expertise and interests lie in the intersection of geriatric population health and affordable technology solutions for seniors. And then, I'm sorry, Dr. Brill, I didn't get your bio, but he's a family medicine doctor. I know that much. Do you want to briefly introduce yourself?
Sure. Yeah, I'm family medicine. My office is with the clinic out in Rocky River. Yeah, area of interest is basically family medicine, and we have a busy practice taking care of pediatrics up to geriatrics. So
Perfect. So thank you guys, and we're very excited to hear about the leveraging interdisciplinary partnerships to elevate the importance of hearing health. So thank you.
Great. Thank you so much, Dr. Koo, for the very kind introduction. Sarah, should I kick off? Is that okay?
Yes, yes, please do. Thank you.
So, we're here to really describe the joyous journey that we've had to leverage this partnership. And these are disclosures for Dr. Sydlowski, myself, and for Dr. Brill. Hearing loss, I don't need to tell this group, it is incredibly important. How important? It's the third most common chronic health condition for older adults, affecting 40 million people, 29 million of whom are untreated, resulting in long-term health consequences and reduced quality of life. And reference from pop culture. Three old men are walking down the street. The first one says, "Windy, ain't it?" Second one says, "Nope, it's Thursday." Third one says, "Me too. Let's go in here and get something to drink." Ah, the fun of getting older. So there are several things wrong with this picture. Two of many are: one, it trivializes hearing loss. Second, it normalizes hearing loss, which is even more condemnable because this is common, but it's not normal. And when you have great hearing, you have great health. But when you don't have it, in the absence of it, you see cognitive decline, social isolation, depression, even mortality, especially with untreated and undertreated hearing loss. Midlife hearing loss is the most modifiable risk factor for Alzheimer's disease. And the pandemic only highlighted the impact of isolation and all the linkages that we've just mentioned. Hearing affects quality and healthcare outcomes, and when it's not present in people with hearing loss in both the volume fee-for-service world and the value-based care world, there are incredible impacts. So higher healthcare costs and poor utilization. When I say utilization of healthcare. So 49% of people who have hearing loss report not having any regular source of care. Not only not seeking that care, but not filling a prescription even when they think it's needed. There's decreased compliance with recommendations, and the evaluation, the patient perception, the patient-physician communication is low across the board. In the value-based world, increased hospital readmissions. In the quality world, increased falls, post-operative complications in older adults undergoing major surgery. So impact across the board. The good news is that with appropriate management of hearing loss, there's a lot of help available. So the use of appropriate hearing devices improves access to sound, cognitive profile, and quality of life. Likely, we think, through the reallocation of these cortical resources that have been altered by hearing deprivation. And while that is great news, 75% of hearing loss remains underdiagnosed and undertreated. 21% of people who need hearing aids actually use them, and only 2% of people who need cochlear implants actually have them. So people are increasingly thinking that hearing loss is important. Who are these people? Well, it's universal. Academic journals like The Lancet, major academic medical centers like Johns Hopkins, CDC, the media, and national and global initiatives. So Healthy People 2030 here in the US, as well as the World Health Organization, all feel that by 2030, we should really accelerate the action and investment on recognition of hearing loss, evaluating it, and doing something about it, managing it. And the winds of change are blowing, as many of you have heard, and people are taking action. And I'll invite Dr. Sydlowski to describe.
Yeah, thank you so much. I don't know, can I stand to the side and hopefully you can still hear the microphone because I'm too short to see over the monitor. So as Dr. Hashmi said, the feeling about hearing loss is certainly changing. And that's really important because it is so critical to many, many other aspects of health. So whether you are a physician who works with patients directly who have hearing loss, or you're just someone who works with people or communicates with anyone in your day-to-day, hearing has a factor. So for a long time, we've been having this conversation about how do we get people to care about hearing? And as we see that more and more health professionals are recognizing that hearing is really important to health, we're able to change that conversation just a little bit. And now we can ask the question, how do we get hearing care to people? And so as Dr. Hashmi said, we know that only a fraction of people who need to use hearing technology are actually using it. The most recent answer to that question has been over-the-counter hearing aids. And I'm sure all of you have heard about this technology. Maybe you're getting questions from your patients. There's certainly been a lot of information in the media, lots of stories that are saying over-the-counter hearing aids are going to change how people approach hearing and hearing loss. And suddenly it's going to be very important and people will be rushing the doors and buying up all the over-the-counter hearing aids. But I think we have to ask ourselves, are we really addressing the root cause of why people haven't moved to action about their hearing loss, or are we just treating the symptom? I think we're probably chopping at the leaves a little bit and saying, let's make sure that we have this technology without really understanding why have people not pursued hearing technology up until now. And if we do have the wrong or a brilliant solution to the wrong problem, that can be worse than no solution at all. We have to be solving for the correct problem. I'm not sure that the correct problem was really the accessibility and affordability that everyone's been pointing to for why we developed over-the-counter hearing aids. So I think we have to go back to that question of how do we get people to care about hearing to begin with? Now, when you talk to patients about their hearing loss, what they want to manage it is an option that's easy, affordable is true, very convenient and easy to access. It takes almost no effort, that can be understood easily by everyone, and that minimizes their change in risk. And many people have thought that the answer to that is this over-the-counter technology. I would say it might be something different. Now, when you talk to lots of audiologists for the last 5 years, at least, Julie, we have had many, many conversations about who is our biggest competitor? Who's preventing us from connecting patients to this care? Do we have to worry about big box stores like Costco? Do we need to worry about online options that people are pursuing? Over the counter for sure, or maybe even consumer electronics. There's lots of work being done to turn AirPods into hearing aids, which should probably be a little bit easier for people to digest because it looks so common. But I would argue that our real competition is status quo, that people are most comfortable doing nothing about their hearing. And so we have this really big challenge where we have to move people from, I'm ready to not do anything, to I think my hearing is important enough that I'm going to take action. Now we have to recognize that people are dealing with status quo bias. It is our natural inclination as humans to want to stay exactly where we are and do nothing different unless we absolutely have to. And there's good science that suggests that when you are thinking about getting people to change, it doesn't actually matter how much better you're going to do The fact that there's a change at all holds people back. And then secondly, you could have a scenario where either you're comparing like it could get a little bit worse or it might get a lot better. And that little worse is going to be weighed much more heavily in their minds compared to something that could be much, much better. So it's something that requires change. And especially if it's something that they perceive might have even a slightly negative consequence, is going to push people closer to the status quo. And interestingly, there's good evidence in the business literature that if you have many options, the dominant competitor becomes more dominant. And the reason for that is that's what's most familiar. So people are going to gravitate toward that option that they're most comfortable with. There is probably the opinion in the audiology world, the hearing industry, that the dominant competitor are the prescription hearing aids that we're all used to. But I would argue that the dominant competitor is do nothing. So when there's all of these options out there, big box stores, online, go get a prescription device, see an audiologist, see an ENT, all these different options, instead of realizing I have great options, I'm going to pick the best one, patients can go, these options are confusing, I'm not going to do anything. So we might actually be creating a scenario where we're worse off, even though we have more options. So how do we begin to close that gap? We have to get patients to overcome this loss aversion, the feeling that going away from the status quo could potentially worsen their situation, or that change is scary. And today, status quo bias, wanting to stay where we are without changing, outweighs the impact that hearing loss is having on people's lives in many cases. And so we have to flip that balance. We have to make sure that the hearing loss and the opportunity to hear better carries more weight than the fear of change or the confusion around taking that next step. Now, we know that when people are going through a change process, which deciding to do something about their hearing loss absolutely is, there are 5 stages of change. People start at pre-contemplation, which probably occurs before they ever show up in our offices. They move to contemplation, then preparation, action, and maintenance. Now, when we talk about hearing loss with patients and the information that we provide from the ads that you see in the media, commercials on television, even information that we provide as professionals about the type of hearing loss you have and the technology you might want to be using, all of that information is targeting patients at that action stage. Now that you're ready to do something about your hearing loss, here's how you take that next step. And I think that is focusing our attention far too late in this change process. We have an opportunity to actually motivate people to want to take that step if we reach them much earlier, maybe when they're in that pre-contemplation or contemplation phase. But that's not when they're in head and neck. We don't have access to patients at that stage. And so instead, we need to rely on our colleagues, and that's where Dr. Hashmi and Dr. Brill come in. So I'll pass it back to Dr. Hashmi to tell us a little bit more about how influential physicians really are in this process.
So thanks, Dr. Sydlowski. Always learn so much from you in terms of change and change management. So change agents, providers and patients as agents of change. Providers, all of us influence health behaviors. We build strong relationships, address concerns and change. And patients are motivated by prevention of other health concerns that are associated. We've talked about what is the anticipated benefit that they'll get. Their confidence is increasingly shaped by clear, specific, feasible plans that are made in conjunction with their providers, with giving some direction to this. So where do patients and providers stand, sort of at baseline or today? So this is from the literature. A study looking at both patients and providers, 250 patients or adults 50 to 80 years old, 9% of whom knew what normal hearing is, compared to 85% of whom knew what normal blood pressure is and what normal vision is. Big divide there, big contrast there. When you asked if primary care providers on the right-hand side, the 400 primary care providers, encouragingly, 95% think that normal hearing is very important for patients to know. But when asked themselves, do you know what normal hearing is, only 57% actually did. Now, on both sides, patient and providers, less than half of patients and providers think that hearing loss is treatable. Less than 20% of patients and less than 17% of PCPs thought hearing loss is preventable. And the upshot of it is patients are twice as likely to take their pet to the vet as to have a hearing test. So what will resonate to change things? So with hearing screening, has to be quick, no added time, has to be easy with no special skills or training, has to be eminently comfortable and comfortable in a way that facilitates a meaningful but time efficient conversation with patients. So in setting the stage for this, we asked our geriatricians, um, should people be screening for hearing loss? And very, encouragingly, almost universally, almost 100% said, yes, you should be doing hearing screens. Regrettably, less than 20% were actually doing this at baseline. And so clearly there was a need for help, which they wanted. More than 80% of the geriatricians said, we want help with hearing screens. We are motivated to do it. We're not doing it right now. And so under Dr. Sydlowski's leadership and Dr. Brill's leadership, we did just that. We sat down with pre-study focus groups. We onboarded our medical assistants and essentially shared the why that we're also sharing with you, this morning. Now, is there precedent? Has this been done before? It has. So in the literature, in the VA, actually mandates hearing loss screening. The identification rates are more than 3 times greater than the general population. There is to date still the largest, I think, most well done randomized control trial, the Say What trial that was done in 2,300 US veterans. And they looked at hearing loss screens with questionnaires, otoscopes, and combined modalities. And the combined modality of the questionnaire plus otoscope was superior than either or alone. Completed audiology referrals were again highest with this combined modality, closely followed by hearing loss screening questionnaires. The AIR-PC study, early auditory referral in primary care, this implemented best practice alerts within the electronic medical record. The results speak for themselves. So appropriate referrals for all patients age 55 plus increased 6-fold. 78% of those who were referred actually had hearing loss and 60% received hearing aids. So there is precedent, it works. So what does the USPSTF, the United States Preventive Services Task Force, say? Well, they say the balance of benefits and harms of hearing loss screening cannot be determined. More research is needed, and they ascribe a grade 1 level of evidence to this. And what does a grade level 1 of evidence mean? Well, it turns out that hearing loss screening joins an august company of other entities, clinical entities that you may know about, including skin cancer, pre-diabetes and diabetes screening for children and adolescents, autism screening in children, in my area of interest in older adults, impaired visual acuity and cognitive impairment screening. So clearly, all of these things are incredibly important. And so notwithstanding these USPSTF recommendations, there's a great editorial by Dr. Yue and colleagues and JAMA in 2021, which said, screening for hearing loss in older adults, insufficient evidence does not mean insufficient benefit. And I think that's true for people of any age. So by this time, Dr. Sydlowski was kind enough to include a stylized photograph of me saying, show me the evidence, and probably you are all thinking the same thing. And so we've gone about with this wonderful collaboration to do exactly that. We've set about to build the evidence base in partnership with audiology, in family medicine, in geriatrics, overall in primary care. So we have a successful aging program at our Center for Geriatric Medicine. This is a physician-led multidisciplinary clinic. It is a prime opportunity for collaboration. It used to be only bricks and mortar. Now it is also on a virtual platform. And the focus of this program is the 4 M's, which has garnered us recognition from the Institute for Healthcare Improvement as an age-friendly health system. Mentation, mobility, medications, deprescribing inappropriate medication. At the core of all of these 3 M's, the 4th M, what matters most to patients. And so you might even say the 5th M of multimorbidity, at the heart of it, hearing loss. And so I'll invite Dr. Sydlowski exactly how we went about implementing the screening.
So as Dr. Hashmi said, we really felt like it was our responsibility at the Cleveland Clinic to make sure that we're adding to that evidence base of why hearing screening for adults is not only effective, but actually essential. And so a couple years ago, we had the opportunity to receive funding from the Healthcare Delivery and Implementation Sciences Center here. We were just refunded by the Catalyst Grant Program moving forward to embed hearing screening tablets within primary care and geriatric medicine initially. And we wanted to have, again, that really simple, easy way for physicians to quickly screen and understand, does this individual have hearing loss? So we embedded 15 tablets in 11 locations, and we asked providers to screen all adults age 50 and over, unless they already were using hearing aids or had occluding cerumen or chronic drainage, or a reason that screening wouldn't make sense. The advantage of the screening system based on these tablets, of course, is that a sound booth isn't required, and it is strictly a screening. It's a pass-fail sort of setting, so it can be completed in 2 minutes. It's typically done as the MAs are rooming patients. And we're going to share with you today some of our preliminary data. At this point, we've actually screened over 2,400 patients. We gathered this first bit of data after our first 1,800 or so. And in that first batch, about 66% of patients did indeed have reduced hearing. Not surprisingly, the older patients were, the more likely it was that their hearing was reduced. Now, what was very interesting is that at the beginning of the screening, before actually doing the hearing testing part, we also asked 3 questions. Have you noticed any difficulty hearing? Has a family member, friend, or loved one noticed or said something to you with concern for your hearing? And thirdly, how important is it to you to improve your hearing today? And interestingly, what we found is that about 3/4 of patients who were screened said that they had no difficulty hearing, and no one had told them that they had any difficulty hearing. But 2/3 of patients did indeed have that reduced hearing. So the number of people who thought they didn't have a problem and the number of people who probably do was actually pretty similar. We also found that because of that, it's important to recognize that using just a question of, do you have concern for your hearing, which is pretty common today in many primary care practices, if they do anything at all, which is actually not that common, it's not that great of a screener. It's very good if someone says, yes, I have concern for my hearing. It's almost certain that they do have hearing loss. But if they say, no, I don't have any concern, it's still very likely, based on their age, the older they are, that they probably do have some hearing loss. And so to use just a screening questionnaire probably doesn't do a great job identifying patients unless they confirm, yes, I have concern. Now, what was also really interesting is that although about 75% of patients said that they did not have concerns and no one else had told them they were concerned for them, about 2/3 of patients said that it was moderately or very important to them to improve their hearing today. So what that really prompted us to think about is how we're asking the question effective. Probably people don't want to acknowledge that they might have a problem or a difficulty or something that they need to change, because remember that patients don't want to move away from that status quo, particularly if it's in what they perceive to be a negative direction. So to acknowledge that they have a problem or a difficulty, and especially one that's very difficult to recognize in oneself, like hearing loss, because you don't know what you're not hearing, makes this probably a poorly formed question. So what we would recommend is that a better question is, would you like to be hearing better? That acknowledges at least that more positive change. It's not having them acknowledge that they have any sort of problem or difficulty, but it does acknowledge there's an opportunity to maybe do even more, which based on our data would suggest that people are more willing to do. What was also interesting is that when we looked at the importance of improving their hearing, there actually wasn't really a relationship between the results of their hearing screening. So even people who passed their screening still thought they had some opportunity to be hearing better. And I think that points to what we know today as hidden hearing loss, where people might be having difficulty hearing and background noise, even though their pure tone thresholds look perfectly normal on an audiogram. So we're in the midst of our analysis phase still right now. We're going to be looking at how physicians behaved when they got this failed screening. Did they put in an order for a hearing test? For patients who had an order placed, did they come for a hearing test? Was the hearing loss confirmed? And ultimately, did that move them to using hearing aids? And then we'll also be looking at the relationship to comorbidities that we know have a relationship to hearing loss, including patients who have cognition codes that have been associated with them, and a history of diabetes or heart disease. So now I'd like to pass it over to Dr. Brill. He has been an absolute superstar physician champion. Probably about 1,000 of the screenings that we just shared with you were conducted in his office. And interestingly, this was the office that I was personally most skeptical about when we started the study. We thought geriatric medicine was going to be the place to really make an impact. And we worried that family medicine is such a busy practice with such a short appointments that screening would be tough. And Dr. Brill's experience proved to us that we needed to think again. So I'll pass it over to him so he can share with you how having these tablets impacted his practice and the outcomes of his patients.
All right. Thank you, Sarah. Good morning. I was originally asked by my chair to look into helping out with this research, partly because our practice is busy. It's not just me. There's about 12 providers in our site, family practice, combination of family practice docs and nurse practitioners, but also because my wife has profound hearing loss, and in the middle of this got a cochlear implant. So I was personally aware of all the statistics from the beginning about the isolation. It's not just the isolation for the person with the hearing loss, it's isolation for the person married to the hearing loss, because you can tend to kind of like, oh, well, she didn't hear me, so I'm going to stop talking anyway. So, I could see it firsthand. What we opted to do, because I knew this was going to be an ask for the MAs more than anything, is we just kind of sat down and incorporated it into our daily rooming. It was 50 and above. We pretty much narrowed it down to patients who were coming in for longer appointments, not the quick sick visits, sore throats, things like that. And then we just made it part of the rooming process. We found that there was a good couple minutes there where the MA was going through other things and inputting, and the patient was just sitting there anyway. So we didn't get much pushback from the patients. They thought it was kind of interesting. It certainly has changed how we approach it. We were talking earlier about the importance of our role as physicians. It always sounds so egotistical, but in the primary care world, you build up relationships, and with these patients I've taken care of for many, many years. And if I convince them to think about something or get tested for something, it'll usually happen. It doesn't always happen, but I think we have a lot of influence as primary care docs to push this needle over a little bit to getting tested. And what we would do is, once if it came back showing some hearing loss, which again was most of them, invariably the patient would tell me, well, it was the air conditioning, or it was this, it was almost every time that, those things didn't fit right, et cetera. And so I would tell them, well, actually it's tested for that. And it doesn't mean you have hearing loss. And I tell them that I failed the test when it first came out, and I had no idea that I would fail that test. And I just tell them, it doesn't mean you have a hearing loss. Doesn't mean, I'm not going to sell you a hearing aid right now. It just means you need it's worth getting a better test, and what you want to know. And I stress the importance that, I talk about how it's the one sense you don't know you don't have. You could be sitting there having a nice conversation with somebody, not even noticing, and the birds chirping behind you, and you don't even notice it. Well, you don't know, you don't notice that. And if you're not hearing that bird, then perhaps part of that brain's just not working anymore. And that usually will catch their attention. I tell them most of the time, you're not noticing it and no one else is noticing it, but isn't it worth getting another test? It'll be interesting to see what the data is and how many of them followed up, but I know quite a few did. I know some of them ended up with hearing aids. It certainly is better than prior to having this, where I would try to, like I said, we'd occasionally ask, or you'd be in the room and like, you can't hear a word I say. And those are the people who are really, really obvious. I'm like getting hoarse because I'm yelling loud enough for them to hear me. This is certainly a little bit better than that. It hasn't been as onerous as we thought. Once we just kind of put it into our routine, it became a part of our rooming process. And I think it's really enhanced my practice, because I'm screening for and catching something that we pretty much weren't screening for or catching at all before. And that's I really think that getting that needle moved, you're going to have to recruit and bring in the frontline docs, the ones who see the patients on a regular basis. I think that's going to be much more effective than all those other marketing tools. So that's my part.
Great. Thanks so much for sharing about your experience. We also, where did oh, hold on. Did I just close out of Teams completely?
No, it's
This one? Okay. Sorry. Thank you. All right. So then we also wanted to share with you what we're doing next. So knowing that we've seen really promising results already, we're hearing great feedback like Dr. Brill's about the experience both for patients and for physician providers. Next, we want to scale the bright spots. So we want to learn from the experience that Dr. Brill and his colleagues are having, and we're going to utilize their experience to engage other primary care providers. The Catalyst grant is going to allow us to embed more tablets into other practices so that we can see how this works in other settings where perhaps we don't have individuals who have the personal experience and commitment to this work that Dr. Brill does. We want to focus a little bit more on targeting high-risk populations. So we're working with some of our colleagues in endocrinology, for example, because we know patients with diabetes have a higher risk of hearing loss as well. Hearing loss screening was actually added to the protocols for diabetes patients, but in talking to our colleagues, that really hasn't been implemented well yet here at the Cleveland Clinic. So we're going to work with them to do that. We're also looking at opportunities to connect tablet screening to evaluations for patients with cognitive decline. I do suspect that oftentimes we start going down that path without realizing that most of the measures that we use for cognitive screening rely on auditory function. So if someone has hearing loss, that could be impacting their results. We're also going to evaluate self-screening compared to screening within a physician practice. So we'll have at least one standalone kiosk, and we're going to compare how highly utilized that is and what kind of actions people take as a result, compared to having that physician there saying, this is important, here's your results, and I recommend that you do something about it. And then lastly, we're very focused right now on how do we improve the experience here at the Cleveland Clinic for patients who have hearing loss. We know that many patients that we see across the enterprise are having these encounters while living with hearing loss. And as we shared with you at the beginning, we know that hearing loss impacts their perception of their patient-provider interaction. It affects their satisfaction with their visits. It increases hospital readmissions because they might not hear their discharge instructions as well. And so because it has such broad implications, we're working with some folks in safety, quality, patient experience, and we're working to develop materials that will be available for all of our caregivers to know how to better interact with our patients with hearing loss. Some of those have been available on the internet recently, and so we'd like to close by sharing a video that is available on the internet. I hope you all will access it. If you haven't already, I'll share it with you now. So I would invite you all to visit that website. There's great communication tips. I'd also ask for your help to spread the word. We're working really hard to reach every corner of the enterprise. And so if you have colleagues, individuals that you know who can help implement some of these recommendations that we've made, we would really appreciate your help to make sure that every caregiver at Cleveland Clinic knows how important it is to treat this special population the way that they need to be treated so that they can get the most fantastic care we can possibly provide. I'd also just like to acknowledge, you saw a lot of familiar faces in that video. So we had many people in H&I who helped make that happen, but especially a big shout out to Brad Bilek, who did an amazing job, I think, pulling all of that together. It's probably one of the things that I'm most proud of that we've done. So with that, thank you so much for your attention, and I'm sure we'd be happy to answer any questions. I think we have some geriatric residents on the line as well. We have a session at 8 o'clock to continue this conversation. So if you have questions for me, please hold them. But if you have questions for Dr. Hashmi or Dr. Brill, now's your opportunity. And then for anyone else who's not in that cohort, we'd welcome any of your questions. Sure.
Thank you. It's really great to see, not just recognizing the problem, but going back to, thinking about the process of, change in decision making and kind of going to that pre-action phase and really like collaborating with, partners outside of your immediate surroundings. Thank you for that. I was just wondering, it sounded like in other studies, a lot of the things they did the, like you said, the questionnaire. And so how did you come up with the hearing screening? Like, what is that composed of? And how was that validated, or why did you choose to use that?
Okay. Yeah, good question. I'm going to repeat it just so everybody online can hear. So the question was, we mentioned that there's questionnaires that have been used for screening, and why did we choose the tablet-based hearing screening, and how's that been validated? So we're working with a company called Shoebox, and they developed this tablet-based system. There are a number of different systems that a task force from the audiology group vetted and kind of looked at like how easy it would be for patients to use, how easy we thought it would be for our physician colleagues to embed into their practices. We looked at things like, how hard was it to push the button? Some of them had a button tap versus a slide. And when we're thinking about older adults, like what would they be able to work most easily? And then we also looked at their data in terms of how effective it was, but also how reliably it could be utilized in a situation where there was some low level background noise, because we expected that these would not be used in an environment that was perfectly quiet. Also, in looking at the study that Dr. Hashmi mentioned, there's been a few, but some looked at just questionnaire, some have looked at an objective screener, and some looked at the combination. The combination did seem to be most effective. And so we liked that this screening tool had both. And then it also collects the data in a cloud-based portal. So just from a logistics perspective, that's been really nice and easy so that we can also track patients. Now that we're beyond the official study phase and we're just embedding these as part of standard practice, that gives us an opportunity to contact patients directly. If they haven't followed up with a hearing test, we can continue to prompt them so that we're not losing them in the system. I do think that what we're learning from this is that question, it probably isn't enough. And I think maybe Dr. Brill can comment on this, but I think the experience even of just pulling out the tablet and giving the impression like this is important enough that we have equipment for this and we're going to take the time to do this helps patients to recognize like this is an important part of my care. This is an important part of my health. So before they even get a result, my opinion is that action means something more than what a questionnaire does. But David, what do you think about that?
Yeah, I mean, for most of the ones that we screened, no one had ever even screened them before anywhere. So just starting that conversation and bringing it up as, well, we're measuring this, and this, and now we're going to measure that. But yeah, it was interactive, and it certainly brought out the conversation. And for a lot of people, no one had ever asked, so then they actually had some issues, et cetera, or they were worried about something because of a family member. So it started a conversation that we had never started.
The other piece I would add is before we ever started this project, I went around for probably a year or two actually just talking with primary care physicians and finding out like what were their barriers. Or how did they normally address this conversation? And what I oftentimes heard is that they would say things like, well, this is common for your age. And so when people would say, I have concerns for my hearing, or what about my hearing? Oftentimes it's like, yeah, that comes along with aging. And so I think people's perception when you hear that is, okay, I don't need to do anything about it. On the other hand, when we take time to screen something like we have your blood pressure checked, in no circumstances is a physician going to say, well, your blood pressure is high, but that's common in older adults. So you should just kind of deal with that or learn to live with it. You're going to manage it. And so I think that when we do the same process, we pull out a tool, we measure how you're hearing, we get an objective result and say, now we need to do something about this. That really changes the conversation from a casual, yep, that's something that comes along with aging to this is a part of your health that we need to manage and care for. Yes.
That was great. Thank you. How many people that we screened actually went on for formal audiograms?
Yeah, good question. So the question was how many people that we screened actually went on for audiograms. We're still analyzing those data right now. As you can imagine, there's a lot to weed through. But I think that's the $1 million question. There's probably a precursor to that is how many physicians put in an order when they saw those results. Audiology, I believe, was actually one of the first departments that had order up functionality. So technically in that order, there's the capability to directly schedule an appointment. And if the order exists and a physician or MA doesn't schedule the actual appointment, patients also get a ticket through my chart that they need to go ahead and schedule. So I don't know how much that functionality has been utilized also, but I think knowing like that we've made it easy for people to schedule and then how many actually taken advantage is going to be an important question that we're still digging into.
Even if you captured like 10% for audiograms, it's still like a ton of volume that we're going to have to figure out how to deal with.
Yes.
That's like a healthcare system.
Julie's probably over here going, yes, that is exactly the issue. Yeah. I mean, obviously we want to increase the volumes. I think a capacity problem is a great problem to have. So I'm very happy to continue increasing demand.
That's what I'm saying.
Any other questions?
In your new position.
Great talk, great initiative. My question is about between hearing decline and cognitive decline. screening program like this would seem perhaps to suggest that we could slow the rate of progression or even the incidence of dementia nationally if something like this was to be scaled. Do we know what age, is there a predictable sort of course? Is there an age range at which we think intervention on progressive hearing loss could actually result in lower incidence of dementia?
Good question. So the question is, do we know an age at which intervening could slow the rate of cognitive decline down the road? First of all, there's been a lot of evidence coming out recently that there is this relationship for sure between hearing loss and cognition. There's also really good evidence that's just been emerging in the last 6 months or so that suggests that use of appropriate hearing aids and cochlear implants can slow that rate of decline. There was a big trial called the ACHIEVE trial, the results of which were just released at the end of the summer, that suggested in adults who had a risk for cognitive decline over a 3-year period, if they were using hearing aids versus a control group who just had education, it reduced the effect on their cognitive ability, their memory functions by about 30%. So it was significant. The challenge that we face right now is that insufficient evidence rating from the U.S. Preventative Services Task Force, because if you ask any primary care provider, the first question they ask is this mandated? Is it on our health maintenance tab? So we're working hard to get that there. In terms of the appropriate age, earlier we know is better. So one of the problems we have right now is that hearing loss increases the incidence the older that you get. So oftentimes we're catching it at 70, 80 and older. But the Lancet study that Dr. Hashmi pointed to suggests that it's the most modifiable risk factor in middle age. So we have to identify people much earlier than we're identifying them today. Catching it when you're 60, 70, 80 is not going to have the same impact. And so when we look at where we start seeing increases in hearing loss incidence, it's closer to 50. And so that was where we set our 50-year-old cutoff as far as the screening that we wanted to do. I think there's a little bit of a misperception for people who are working with patients who have cognitive decline diagnosed already, that if they start using hearing aids, that's going to have an impact. It's probably much too late. So we need to find a way to catch people, like I said, when they're thinking about doing something about hearing loss, more as a preventative measure, as opposed to here's how we're going to treat it. So thank you for the question.
There's a comment.
Oh, okay.
On the chat if you want to.
Thanks. All right. Oh, this is a great comment. Dr. Brill is a real champion for his patients. I totally agree. Does he feel that his personal connection and experience has influenced the implementation of hearing screening and referral in practice? Can this be leveraged to increase uptake of such screens system-wide? Personal stories always seem to help drive advancements and improvement in patient care.
It definitely influenced me getting involved. But now, as you've been in this for a little while and read all this research I wasn't really looking into, and seeing that it's important for my patient, that's kept me going. To be perfectly honest, though, some of the other providers in my practice, that's in my site, the ones I work with, are hesitant to get involved. Same thing. We're like, well, as soon as it's required, I'll do it. But we've got so many other. There's just so many boxes that we have to check at every single visit now. But yeah, the personal, it gives me a little bit of an advantage, because even when I find someone that has an issue and they're on the fence, I can tell them about my experience with my wife, or the fact that I failed the test and I don't need hearing aids yet, etc. But you're right, any kind of personal touch helps. It got me involved, but now I'm doing it mainly for the patients. I just think it's a good thing to be doing.
And kind of like what you were mentioning about having like stand-alone kiosks. I think that makes me think of like, when you go to CVS or Walgreens, they have like the blood pressure thing where people are just waiting around. They're like, oh yeah, let me go check. I think that would be a great way to, it's not going to capture everyone who obviously need that extra motivation. But if anyone wants to just do a quick self-test, and then maybe at the end have like a short, educational video or whatever about the importance of hearing and all of these things, because I think awareness is the other big part of it. And then having like an option to like schedule an audiogram right there, at the end of the test that may capture a population who are a little bit more motivated or, don't need a direct physician interaction to get them to the audiogram.
Yeah, I think you're exactly right that, we think about that change process. If we catch people when they're contemplating, first we just have to pique their curiosity. And so long as we get them curious first, that opens the door for us to educate them more about the opportunities to hear better and why that matters for their health. I know we're up against time. The one last thing I just wanted to mention is that we are putting a team together right now to use A3 thinking, which is a continuous improvement methodology to tackle really complex problems where we don't know the answers. We're going to put that team together to tackle how do we improve that patient experience across the enterprise for patients with hearing loss. It will probably include things like how do we better identify these patients through EPIC? How do we make sure caregivers know how they need to communicate most effectively? So if you have any interest, having heard this discussion today and would like to be a part of that work, please feel free to email me. We'd love to get more people involved. Thank you very much for your time and your interest today. And thank you so much to Dr. Hashmi and Dr. Brill for your partnership and for presenting today.
Thank you. Thank you.
For the geriatric residents on the call, I'm going to change rooms and log on to that other link that we have. So I'll see you in like 5 minutes.
Thank you, guys. Thank you, everyone. Thank you, Dr. Hashmi and Dr. Brill. Thank you so much.
Bye-bye. Thank you.